iTech India welcomes all the participants. Today's regional distance
will
learning.
come or what?
Sorry,
It's all
screen
right.
is visible. Screen is visible.
You continue. You continue.
Yeah, yeah, thank you. iTech India welcomes all the participants. Today's regional distance learning seminar series.
Okay.
Uh, Today's topic is PPTC, CT and ART in pregnant women. And today's speaker is Dr. Rajeeb Day, iTech India technical specialist. We welcome you, sir, and request you to start the session. Any problem, sir?
No, it's all right now. So it is visible, no?
Screen is visible, but not in full screen mode. Please click on that enable editing button and
I'm audible also. Visible?
yes, yes.
Hello.
Please continue. Yes, please continue.
Screen is visible and audible. Okay, okay. Then good afternoon, everybody. Myself, Dr. Rajeeb Day, and today we'll be discussing about prevention of parent-to-child transmission of HIV. This is really a recapitulation of the session taken in the NDLS by Dr. in July 2022. Now, through this session, we are aiming to know what are the PPTCT services that are available in India and what are the burden of PPTCT in India and the different kind of services that are packaged under the heading PPTCT and the four-pronged strategy to prevent parent-to-child transmission of RT, I mean HIV, and the kind of infant prophylaxis that are indicated for a particular baby, depending on the high risk baby or low risk baby, and the duration of ARV. And then at the last, we'll go through different real time, practical cases of ARV and the PPCT. The total CLHIV living with CLHIV in India was 81,430, and which accounted for 3.5% of the total HIV estimates. And in the same year, estimated 20,930 number of pregnant women who required antiretroviral therapy to prevent mother-to-child transmission of HIV. Now, let us go through without like ART, single drug, double drug, and triple drug, and with or without breastfeeding. So, if we go through it, we see that without any ARV prophylaxis and with breastfeeding, the chance of HIV transmission from mother to child is as high as 30 to 45%. While without any ARV and without any breastfeeding, it reduces to 20 to 25%. On the other hand, if we look at the last two rows, that is 3 ARVs with breastfeeding, the chance is 2%, and 3 ARVs with no breastfeeding, it is 1%. So here we need to recognize that without any intervention also, all the patient doesn't develop HIV by getting it through from mother. And with the highest intervention that are possible today also, we cannot eliminate the total risk of HIV transmission because with 3 ARV and with no breastfeeding also, it is 1% risk is there. And with breastfeeding, it is 2%. Okay. Now, let us see what are the services that are available in India under PPTCT and their aim of the PPT services in India. The Prevention of Parent-to-Child Transmission program is being implemented under the National Control Transmission, where the vision is that women and children should live longer, healthy, and without any HIV. And the goal is to work towards elimination of pediatric HIV and improve maternal, newborn, and child health and survival in the context of HIV transmission. And the main key objective is to integrate PPTCT services with the existing RCH program, that is reproductive and child health program, through NHM, the where all the pregnant women are being registered under antenatal care and natal care. Now, India is also committed to eliminate mother-to-child transmission so that no child is born with HIV and the mothers are kept alive, healthy, so that they can take care of their children. And the target for that to achieve is that 95% of all pregnant women are to be registered for antenatal care and receive at least one antenatal care checkup while they are pregnant. And out of that, at least 95% of the pregnant women are tested for HIV. And out of that, all those positive pregnant women, at least 95% women should be on ART. So these are the targets of this antenatal care and the packages that have been provided under the PPT services are that routine HIV counseling and testing of all pregnant women in the antenatal care with the provision to opt out. We cannot force a woman. Women should decide for her own, and there should be a provision to opt out and ensure involvement of spouse and family members. That is, to involve the family members so that we can go for index texting and all in the spouse and also pregnant lady right from the beginning of pregnancy, and provide lifelong ART as per national guideline to all pregnant and breastfeeding HIV infected women, regardless of CD4 count and clinical stage. And this is obvious because we have gone to the treat all policy, so we do not take into consideration CD4 count or the clinical stage. We start ART as early as possible and provide care for associated condition like STI, otherwise hypertension, diabetes, that is NCDs, and promote institutional deliveries of all HIV infected pregnant women. Because to provide all those services, the patient need to be admitted in the institutions because all services are not possible to provide if the patient delivers at home. And also perform the plasma viral load of the pregnant lady after 32 weeks of gestation. And this is done to know the possibility of transmission of HIV infection from mother to child. And based on this plasma viral load, whether suppressed or unsuppressed, there are different ART regimen and duration of ARB prophylaxis in infant that we will see later. And to provide ARB prophylaxis to the infant as per national guideline, and nutritional counseling, psychosocial support to HIV pregnant, HIV infected pregnant women, and provide counseling and support for initiation of exclusive breastfeeding within an hour of the delivery as the preferred option and continued for 6 months. We'll see into detail this in the coming slides, and integrate follow-up of HIV exposed infant to routine healthcare services, including immunization, and which is also carried out under NHM. Now, ensure initiation of CPT and early infant diagnosis using HIV TNA PCR at 6 weeks of age onwards as per NACO EID guideline. And then strengthen follow-up and outreach through local community network to support HIV positive pregnant women and their families. Because in HIV, in the pregnant lady, it's difficult to travel frequently to the ART centers, so we need to go for case-specific plans how to provide them care and provide the ART to the pregnant lady while they are at home. So, if we consider the prevention of parent-to-child transmission, there are four-prong strategy. There is the four approaches that we can take are there. First is the primary prevention when the patient, that is the adolescent woman or the newly married woman, are HIV negative. We should try our level best to prevent the lady becoming HIV positive through different preventive measures. And these have been taken care of by the ARS clinic and the RCH program. Then HIV, if we fail to prevent the lady from becoming HIV positive, and if she becomes HIV positive, then we try to prevent unwanted pregnancies. And if we fail to do that, and the patient become HIV positive, then our attempt is to prevent the transmission of HIV from mother to child. And we refer the cases as per need, like for the EID and for initiation of ART in the children if it is found to be positive later on. So the risk assessment in case of HIV positive pregnant lady, the chance of risk of the baby to get the HIV infection is based on these facts on the left hand side. That is recent HIV infection in the mother. That means the patient is recently diagnosed with HIV. The patient is ART naive, and as such, the viral load would be very high. So the risk of transmission would be high. Then presence rate, the chance of transmission of HIV is higher. And then the obstetric procedures. The forceps or vacuum delivery, prolonged labor, invasive fetal monitoring gives rise to high chances of transmission of infection. And maternal malnutrition and conditions of breast like sore nipple, breast abscess, mastitis, etc. And there are certain infant related factors which also promote transmission from mother to child, as and these are preterm or low birth. Mixed feeding, as you know, if we go for mixed feeding, there are different proteins coming in from outside, and this can give rise to ulcers in the GIT, which gives rise to high risk of transmission. Now, PPTCT interventions that are provided in India under NACO during pregnancy are, first of all, information to all pregnant lady about antenatal visits, their importance, and we provide all the PPTCT services during that antenatal care and prevention of PPTCT through ART. We should counsel properly the need of ART and drug adherence so that the patient continues medicine as per our advice, and we and the transmission of HIV from mother to parent, mother to child is prevented. And referral for viral load between 32 to 36 weeks, basically after 32 weeks of pregnancy, for determining the type of ARV prophylaxis that the child will require in the postnatal period. Then counseling for institutional delivery so that all the interventions of PPTCT can be undertaken, and counseling on infant feeding practices like exclusive breastfeeding, etc., and ARV prophylaxis for the child and save obstetric. Now, infant feeding options, there are basically two, exclusive breastfeeding and the exclusive replacement feeding. Exclusive breastfeeding means that the baby is fed only milk and nothing else, no other liquids, solids, or not even water. However, drops of syrups containing vitamins, minerals, medicines, or vaccines are allowed. Now, why this is required? This is required to provide the infant with all the required nutrients and immunological factors, because in India, the malnutrition, prevalence of malnutrition is also very high in the newborns. So by providing exclusive breastfeeding to the infants, we will be increasing the likelihood of survival of the baby by providing immunological factors to fight against infections and to provide the required nutrition. And it has to be started immediately within 1 hour of delivery, whether it is normal vaginal or cesarean section. And these initiatives maximize the chances of survival of the infant and is preferred choice of infant feeding for HIV exposed infants in India. Now, there is another mode of feeding. It is exclusive replacement feeding. Is the process when the breast feeding is not adequate for reasons of maternal reasons, or there is a or if there are no fraction of breast milk ready, then we go for exclusive nutrition feeding. Then we add animal milk, dairy milk, and infant formulas. Uh, Important thing to remember here is that you should prepare the feed in a hygienic manner and should be given with a spoon and a bowl and not bottle feeding because hygiene of bottle feeding is not that much as compared to human bowl. Now, mixed feeding increases the risk of transmission, as we already discussed earlier. Uh, so we should avoid mixed feeding. However, if exclusive breastfeeding is not possible for any reasons like maternal sickness, mothers and healthcare workers can be reassured that maternal ART reduces the risk of postnatal HIV transmission as compared to mixed feeding as well. Because if the mother is put on ART, the mother will secrete those ART in the breast milk, and if the patient takes breast milk, then the baby will also get the ART in the form of breast milk. So it will also prevent transmission. So we need to reassure. First of all, we'll try to provide exclusive breastfeeding, but if it is not possible, then we should to reassure. We should not make the patient and the attendant panic about it. Reassure that still there are less chance of transmission. Then healthcare providers and counselors should be trained to help pregnant women in reaching the right decision and to support them in their preferred choice. It is because we all know whoever ever worked in ART center, they know it very well that it depends on the health service provider to assist the patient to come to the right conclusion and to take the right decision. So we should be proactive for that so that all the pregnant ladies go for the right decision, which is best for their health and their baby's health. The current national guidelines for infant feeding in HIV exposed and infected infants less than 6 months of age. So we already said now it is more in detail. Exclusive breastfeeding for the first 6 months of life is recommended. Beyond 6 months of age, breastfeeding should continue while complementary feedings are being introduced. And breastfeeding should stop only when the nutritionally adequate and safe diet without breast milk can be provided to the child. And mothers living with HIV should breastfeed for at least 12 months and may continue even up to 24 months or beyond, like the general population if they are on ART. And the adherence to ART is adequate, that is more than 95%. So current guidelines for infant feeding in HIV exposed and infected infants less than 6 months is that if the HIV positive mother plans to return to work, she can be reassured by healthcare workers that shorter duration of breastfeeding of less than 12 months is also better than never initiating breastfeeding at all. The breastfeeding is made safe by giving ART to the mother and ARV prophylaxis to the baby. And with the optimal adherence to ART and a suppressed maternal and viral load, there remains no difference in infant feeding guidelines for HIV exposed versus unexposed infants. We'll see in detail in the coming slides. Uh, then mothers should follow protective sex practices and ART adherence to the and should have a at ART adherence of more than 95% to reduce the risk of HIV transmission to their babies. So ARV prophylaxis of pregnant women that we were discussing that based on the treat-all policy, all the pregnant ladies who are HIV positive should be put on fixed dose combination of triple ARVs. Currently, the prescribed guideline is TLD, that is tenofovir, lamivudine, and dolutegravir, irrespective of CD4 count or clinical stage. And in practice, basically, we attempt to start ART on the first day of presentation of the pregnant lady, first pregnant lady. And for exposed infant, it depends, the prophylaxis depends on the risk of HIV transmission. Single drug ARV prophylaxis is advised for infants born with low risk of HIV transmission for a period of 6 weeks, regardless of the type of feeding. But if the baby is born with high risk of HIV transmission, then the duration of which will depend on the feeding type. That is, 6 weeks without breast exclusive breast without on replacement feeding, and if it is exclusive breastfeeding, then 12 weeks 12 weeks, the ARV prophylaxis should be provided to the children. So how does it work? ART in pregnant lady, how does and breastfeeding woman, how does it work? It reduces the maternal viral load. We know. So this is the key here that we should start ART as early as possible so that the ART can suppress the viral load in the pregnant lady. And this might take 2 to 3 months. Used to take 2 to 3 months in case of TLE, but with TLE it is faster. Maybe 1 to 2 months time, they suppress the viral load in the mother, and this leads to uh, less virons in the breast milk or in the placenta, and it also further loads the fetus with ARV that prevent the transmission of virons from the from mother to child, and improving overall health of mother and reducing the risk of transmission to HIV exposed infant. ART regimen in pregnant and breastfeeding women with HIV, as we already seen that the preferred regimen is ELD, that is tenofovir, lemibudin, and dolutegravir. The doses, the combination is 300 milligram tenofovir, 300 milligram lemibudin, and 50 milligram dolutegravir to be given once daily, and including it has spectrum of activity on HIV-1, HIV-2, HIV-1 and 2, and women who were exposed to nevirapine single dose in the previous pregnancies. And this can be given with co-infected TB or hepatitis. And pregnant women with HIV should be educated about the benefits and risk of DTG to help informed choice. So here it is important to know that there is a risk of a neural tube defect in the babies if the dolutegravir is exposed to the baby in the first month of gestation. And for all practical purposes, the patient get to know that they are pregnant only after a few months, maybe after 2 to 3 months. So by the time a patient is diagnosed with pregnancy, they have already crossed the first month. And so the dolutegravir should be continued in those patients. Care and assessment of women presenting directly in labor. Labor room nurses offer bedside counseling and HIV screening is done. If the woman is found to be positive on whole blood finger prick test, then the MO in charge will start TLD and ensure that HIV confirmatory test is taken in the ICTC. And labor room nurse informs the ICTC counselors and lab technician for further confirmation of HIV status as per guideline. And if the patient is tested negative at ICTC, the ART is stopped. Otherwise, the ART is continued for the whole life. And after linking it with the ART center and other investigations and undertaken like CD2 count and other baseline investigations or guidelines. So active pregnant woman presenting in active labor, the regimen is TLD, preferred regimen is TLD, and it to be continued in the postpartum if the same dose, that is 300 milligram of tenofovir, 300 milligram of lemibudin, and 50 milligram DTG, which comes as a FDC, a single pill. So the risk of, based on the risk of HIV transmission in the infant, and the prophylaxis that are been recommended are that if the risk is low risk, if the viral load is less than 1,000 copies, if it is done after 32 weeks of gestation pregnancy, then we should provide single drug nevirapine or zidovudin in situations where nevirapine is not effective. For example, infant born to mother with confirmed HIV-2 or HIV-1 and 2 combined infection, or infant born to mother who received single dose nevirapine in their previous pregnancies, an infant born to a mother who is on PI-based regimen due to treatment failure. Now, duration of prophylaxis is from birth to 6 weeks of age, irrespective of breastfeeding practices, because the baby is with low risk of HIV transmission. When zidovudin syrup is not available, we can start lopinavir after 14 days of birth. So in the program, we know it is very difficult to get a zidovudin syrup. So those patients where they need zidovudin, we will be starting this lopinavir after 14 days of birth. Then HIV risk, the high risk patients are those who are born to mothers and who are not on ART, and maternal viral load not done after 32 weeks, or if done, it is it is unsuppressed viral load, and mother newly identified HIV positive within 6 weeks of delivery. So these are the condition when we consider that there is high risk of transmission of HIV from mother to child. And accordingly, the option for ARB prophylaxis are combined nevirapine, zirobudin. That is, dual drug prophylaxis is to be given, and duration of dual drug prophylaxis depends on the practice of feeding, infant feeding. In case of exclusive replacement feeding, it is up to 6 weeks of age, and in case of exclusive breastfeeding, it is up to 12 weeks of age. When zidovudine is not available, syrup nevirapine should be used for the first 14 days after birth, and thereafter lopinavir ritonavir to be added from 6 weeks in case of exclusive lopinavir ritonavir to be added on the 15th day, and it should be continued up to 6 weeks in case of exclusive replacement feeding and 12 weeks in case of exclusive breastfeeding. Another alternative that can be used in this situation is to provide ZLM, pediatric formulation, where we do not have, say, zidovudine syrup, and lopinavir ritonavir also delayed for 14 days. So in those cases, we can go for administration of zidovudine, lamivudine, nevirapine, FDC, pediatric formulation. Now, dose of nevirapine is 10 milligram per ml. So from at birth, if the body weight is 2 kg to 2.5 kg, we provide 1 ml, that is 10 milligram. And if it is more than 2.5 kg, we provide 15 milligram, that is 1.5 ml once daily. And beyond 6 weeks, up to 6 months, it is 20 milligram, that is 2 ml once daily. And more than 6 months to up to 9 months, it is 30 milligram, 3 ml. And beyond 9 months, it is 40 milligram once daily, that is 4 ml once daily. So infant weighing less than 2 kg, the suggested starting dose is 2 milligram per kg once daily. And nevirapine dose for older infants is provided in a situation where HIV exposure is identified during infancy, the mother is breastfeeding, and the infant is either HIV uninfected or the status is yet to be determined after taking opinion from SASAP or UAE. Any HIV exposed breastfeeding baby beyond 6 weeks of age will need SASAP or UAE opinion for indication of well prophylaxis. Now, the dose of zidovudine is 10 milligram per ml. So less than 2 kg, 5 milligram per dose twice daily. That is 0.5 ml twice daily for 6 weeks. And 2 kg to 2.5 kg, it is 10 milligram per dose twice daily. That is 1 ml twice daily for 6 weeks. And more than 2.5 kg, 15 milligram per dose twice daily. That is 1.5 ml twice daily for 6 weeks. So these charts are important to be kept ready for reference on our day-to-day practices on our table, because going by memory, we might do mistake. So it is a good practice to refer to these tables during prescription to the baby. Use of syrup nevirapine, lopinavir ritonavir. Syrup lopinavir ritonavir should be used for infant prophylaxis in certain specific situations, and it should be used only after 14 days of birth, that is from the 15th day onwards. When zidovudine syrup is not available, lopinavir ritonavir should be used after 14 days of birth. When zidovudine syrup is not available, syrup nevirapine should be used for 14 days, and then lopinavir ritonavir to be added uh, from the 15 day and till 6 weeks in case of exclusive replacement feeding, and 12 weeks in case of exclusive breastfeeding. Now, dose of lopinavir 80 milligram by 20 milligram per ml. So, birth to 2 weeks is not indicated. It is rather contraindicated because of side effects. And 2 weeks to 4 weeks, if the baby is 2 to less than 3 kg, it is 0.6 ml twice daily, and 3 kg to less than 4 kg, it is 0.8 ml twice daily. If the weight is 4 kg to less than 5 kg, it is 1 ml twice daily. And beyond 4 weeks, if the weight is 3 kg to less than 6 kg, it is 1 ml twice daily. and 6 kg to less than 10 kg, it is 1.5 ml twice a day. Now, infant ARB prophylaxis should be started immediately after birth or at their first encounter with the health services. Now, it can be started even after 72 hours, unlike the PEP, that is post-exposure prophylaxis, which usually is not indicated after 72 hours. But in case of infant ARB prophylaxis, even if the patient comes beyond 72 hours, we have to start ARB prophylaxis because it will prevent transmission of HIV from mother to child through breast milk. Daily infant ARV prophylaxis should continue for a minimum of 6 weeks, during which the mother should be linked to appropriate ART services. A longer duration of prophylaxis is needed for infants on breastfeeding, that we have already seen earlier. Now, duration of infant ARV prophylaxis. Infant with lower risk of HIV transmission, with or without breastfeeding, the duration is 6 weeks. And infant with high risk of HIV transmission, with exclusive breastfeeding, it is 12 weeks, and with exclusive replacement feeding, it is. So you'll, now, specific interventions during infancy. Uh, we should observe for signs and symptoms of HIV infection, the babies in the postnatal period when the patient is on ARV prophylaxis. And all HIV exposed infants should receive quatrimoxazole starting from 6 of age, and they should follow the standard routine immunization schedule as that of the healthy child without HIV. And they should attend well baby clinic with an early infant diagnosis through a total nucleic acid PCR test and confirmatory test at 18 months with the triple HIV antibody test. Ways in which ART reduces risk of PPTCT that we have already seen. Again, let us recapitulate. It reduces viral replication and maternal viral load, and it also loads the fetus with ARV that prevent placentally transmitted virus from replicating and treats maternal infection, protects the HIV exposed infant from HIV infection, and improves overall health of the mother. So we have gone through this topic now. If there is any confusion, you can ask me, or if there are some questions, you can write it in the text box also. Or shall we take Kiranji? Shall we take the questions after the case scenarios or right now?
No, no, after case scenario, we will take.
Case scenario? Okay then. So let us continue. So case one, on the left hand side, the case scenario is that Mrs. A was initiated on ART in 2018 with TLE. She is adherent to ART. She has now reported to the ART center and informed that she is 2 months pregnant. Her latest result of viral load testing is TND, that is suppressed. As a medical officer, what action will you take? So let us first think of the case and then we see on the explanation on the right hand side. First of all, we need to counsel her with respect to transitioning to TLD regimen because it is the best regimen. The suppression rate is faster than any other ART regimen. And then there is need of ART adherence more than 95%, and we need to link them to the PPTCT program, and they should follow protective sex practices to avoid fresh HIV infection, and institutional delivery for interventions during labor and delivery, and timely ARB prophylaxis to the baby, feeding practices and care for breast and nipples, nutritional supplements, regular antenatal visits, and iron, folic acid, and calcium supplementation. So here, one important thing is that when we transition a patient from any regimen to TLD, and at the same time in pregnancy we are providing iron, folic acid, and calcium, there are certain precautions we need to take. That is, this cation containing iron, folic acid, and vitamin supplements, they interact with TLD and makes the regimen ineffective. So we'll have to take 2 hours before or 6 hours after consumption of iron, folic acid, calcium supplement. This we need to explain to the mother. Then case scenario two. Mrs. C received triple drug ARV prophylaxis in 2012 during her first pregnancy. She was advised TLE once a day as prophylaxis and it was stopped 7 days after discontinuation of breastfeeding. Now she reports to the ART center with 2 months of pregnancy. Her latest CD4 count is 420 cells per cubic millimeter. Now the question is, what ART regimen we should prescribe to this lady? Number one. So, as the guideline says, the preferred regimen is TLD. So we should not go for TLE. We should go for TLD once a day. Now, question two: mother's viral load result done at 34 weeks of gestation was 500 copies per ml. That is, it is suppressed because suppressed viral load means any viral load less than 1000 is said to be suppressed. So she plans to breastfeed the baby. What infant prophylaxis should be advised and for what duration? So it is the case where the baby is with the low risk of HIV transmission. So infant prophylaxis should be nevirapine once a day for 6 weeks. And we have seen earlier that in case of low risk babies, that duration of ARB prophylaxis is only 6 weeks, irrespective of feeding pregnancy. Now, the third case is Mrs. D has reported to ART center at 7 months of pregnancy. She is ART naive and her CD4 is 385 cells per cubic millimeter. Question one: what ART regimen should she be initiated on? So, so as because she is ART naive and the preferred regimen is TLD, so we will start TLD once a day. And mother's viral load report done at 36 weeks of gestation was 20,000 copies per ml. So it is a high risk pregnancy because the viral load is not suppressed. It is more than equal to 1000. So it is unsuppressed. And she also plans for breastfeeding the baby. So what infant prophylaxis and for what duration we should advise? Because it is high risk. So if she continues breastfeeding, the prophylaxis has to be for 12 weeks. And because it is high risk, the regimen should be a dual ARB prophylaxis, which is syrup nevirapine and syrup tirobutin. I hope it is clear to everybody. If you have any confusion, you can stop me in between. Now, case 4. Mrs. E was advised a single dose of nevirapine prophylaxis in her previous pregnancy in 2011. She was later initiated on TLE in 2014. She now reported to ART center at 3 months of pregnancy. What ART regimen should be initiated? So it is a case of exposure to single dose nevirapine. So TLE to be as in the previous case we have seen, we are to transition the patient from TLE to TLD after explaining the risk and benefits of DPD. And the second question from the same previous question, the second question from the last case scenario is that mother's viral load report done at 33 weeks of gestation was 250 copies per ml. That means this is suppressed viral load. So it is a low risk one. The baby should be advised zidovudin. Why? Because the patient was exposed to single dose nevirapine in the previous pregnancy. So we will prescribe zidovudin. And duration of ARB prophylaxis should be 6 weeks because it is a low risk baby. And case 5. Mrs. F is an asymptomatic postnatal PLHIV who presents at the ART center 3 days after delivery. Her CD4 count is 550 cells per cubic millimeter. She has opted for exclusive replacement feeding. The weight of the baby is 2.4 kg. So, what is the next step in the management of the mother? First of all, the points that we need to consider is that the patient CD4 is 550, that is, immune suppression is not that much, and she has opted for exclusive replacement feeding. But her regarding her viral load, we do not have any clue. So Mrs. F needs to be started on ART immediately after explaining the need for lifelong ART with proper adherence, with more than 95%. So we will advise TLD once a day, and we should link the patient to PPTCT, and we should counsel about the feeding practices and care of breast and nipple. nutritional counseling, and safe sex practices. Now, what is the next step in the same case scenario regarding management of the baby? Baby should be advised a dual ARV prophylaxis, syrup nevirapine once a day and syrup zeroburin twice a day, both to be given till 6 weeks of age. Why it is a high risk? Because uh, the viral load is not done. We do not know anything about the viral load. Now, ARV prophylaxis may work even after 72 hours of perinatal exposure of HIV viruses in the baby by preventing the transmission through breast milk. Okay, exclusive replacement also. So unlike the general population, post-exposure prophylaxis is not given beyond 72 hours, but in case of infant prophylaxis, it can be given. So we give it as the mother is ART name, her baby becomes a high-risk infant for HIV transmission. Hence, the baby will be advised two drugs for ARV prophylaxis, that is nevirapine and zeroburin. However, the duration would be 6 weeks because the patient would be on exclusive replacement feeding. Case scenario 6. Mrs. G was screened for HIV and found to be reactive by finger prick test performed in the labor room. She was immediately given a single tablet of TLD. She was linked to an ART center the next day after a confirmatory test report for HIV was positive. Weight of the baby is 2.8 kg. What is the next step in the management of the mother? So, Mrs. G needs to be started on ART immediately from the ART center, explaining the need for lifelong ART with adherence more than 95%, and TLD one tablet once a day, and linking to PPTCT program, feeding practices and care of breast and nipple, nutritional counseling, protected sex practices. Now, the second question from the same case scenario is what advice needs to be given for the baby if mother opts for breastfeeding? Baby should be advised dual ARB prophylaxis, syrup nevirapine once a day and syrup zeroburin twice a day, both to be given for a duration of 12 weeks. Syrup nevirapine should be 1.5 ml once a day, and syrup zeroburin to be 1.5 ml twice a day. Because the mother is ART naive, so the baby is a high risk pregnancy, a high risk baby, and hence the baby will be advised to ARB prophylaxis, nevirapine zeroburin, and duration should be 12 weeks as the mother has opted for breastfeeding the baby. Case 7. Mrs. H is a 24-year-old newly diagnosed HIV positive pregnant woman linked to the ART center. She has confirmed HIV-1 and HIV-2 co-infection. She is 3 months pregnant and her CD4 count is 700 cells per cubic millimeter. So it is newly diagnosed, means high risk, and she is pregnant for 3 months. So what ART regimen should be started for Mrs. H? H needs to be started on ART immediately with proper counseling for lifelong ART and with the adherence of more than 95%. And the regimen should be TLD, as we all know, it is the preferred regimen. And TLD is equally effective against HIV-1 and HIV. Then the second question from the same case scenario is mother's viral load report done at 36 weeks of gestation, target not detected. So she plans to breastfeed the baby. Syrup zeroburin twice a day is the drug of choice for prophylaxis. The explanation is nevirapine will not be effective against HIV-2 infection, we all know. And zeroburin is the choice of ARV prophylaxis in babies born to confirm HIV-2 or HIV-1 and 2 co-infection. As mother's viral load report done at 36 weeks of gestation is suppressed, that is less than 100 copies per ml, the baby becomes a low risk infant for HIV transmission. Hence, the ARV prophylaxis would be for 6 weeks, irrespective of the type of feeding. Now, case 8. Mrs. I, a newly diagnosed PLHIV, has been recently linked to an ART center with a 3 months old baby who is breastfeeding. The recently diagnosed is high risk, and how will you manage her? So we should initiate TLD immediately after adequate preparedness counseling. Advise the mother regarding care of nipple and breast, feeding counseling, and protected sex practices to prevent reinfection from unprotected sex. Case scenario 8. continued. There is the second question from the same case is, how will you manage the baby of this real HIV? We should send DBS sample for total nucleic acid PCR HIV as per EID algorithm. We should start CTT from 6 weeks. Ideally, the baby should be evaluated by a pediatrician for presence of clinical signs of HIV infection. Key referral to support PCOE for opinion on the management of HIV is needed to be sought, and immunization for the baby as per national immunization schedule. If TNA PCR is negative, we need to keep the baby under close follow-up. And at 6 months of age, we should perform rapid antibody tests. And if it is positive, then we subsequently go for TNA PCR as per EID algorithm and take further decision accordingly. And whatever we do, ultimately at the 18 months of age, we should go for the confirmatory test as per guideline. Now, case scenario 9. Mrs. K was diagnosed HIV infected recently. She has reported to an ART center and informed that she is 6 months pregnant. Her CD4 is 285 cells per cubic millimeter. Now, diagnosed recently means high risk, and CD4 also shows significant immune suppression. So, what regimen, ART regimen, should be started in the PLHIV? The patient should immediately to be put on ART with PLD once a day with proper counseling for lifelong ART and adherence more than 95%. And she should also be started on CPT as the CD4 count is less than 50 for the national guideline. The second question in the same case scenario is that mother's viral load report done at 36 weeks of gestation is 5,000. It is unsuppressed. That is, it is a high risk. Baby is high risk for HIV transmission, and the mother has plans to breastfeed the baby. So, what infant prophylaxis should be advised and for what duration if syrup nevirapine is not available? We have seen earlier, if the baby is advised, first of all, because it is a high risk pregnancy, the baby is a high risk baby, so we should start dual ARB prophylaxis with syrup nevirapine and syrup zidovudine. But zidovudine cannot be given within 14 days of life, so we can give syrup nevirapine and syrup lopinavir. So, sorry, if zidovudine is not available, then we go for syrup lopinavir ritonavir. We should be started after 14 days of life, that is from the 15th day onward. So syrup nevirapine once a day started immediately after birth, continued till 12 weeks of age because the mother wants to breastfeed the baby. And syrup lopinavir ritonavir should be started twice a day on the 15th day and continue till 12 weeks of age. The explanation we have already said along with these rules. Duration is 12 weeks, we all know, because with a high risk baby and the mother opts for exclusive breastfeeding. Case 10. Mrs. L, 26 years, was registered at the ART center in 2012. She was initiated on ART with TLE in 2015. She became lost to follow-up LFU after 1 year as she shifted to her village. She has now reported in active labor. How should we manage this patient? First of all, we should transition the patient to TLD because it is the preferred ART regimen for pregnant HIV positive ladies. She should be linked to the ART center the next day for restarting lifelong ART. And we should advise the mother regarding role of ART adherence more than 95% for her health and preventing the transmission of HIV from her to the baby, and care of nipples and breast, and feeding counseling and protected sex practices. So second question from the same case is that Mrs. L delivered a baby by normal delivery with a weight of 3.2 kg and has opted for breastfeeding. So high risk dual drug, and since the breastfeeding, so it has to continue up to 12 weeks. And since zidovudine is not available, syrup zidovudine is not available, the, and if syrup, zidovudine, and lopinavir are not available, baby can be advised pediatric Zedalan. We saw it in an earlier slide that if zidovudine is not available, we can go for lopinavir. If lopinavir, zidovudine both are not available, we can for Zedalan FDC pediatric FDCs as per weight band till 12 weeks of gestation. The dose is 60 milligram one dispersible tablet twice a day for 12 weeks. As the mother is ART naive, her baby becomes a high risk infant HIV transmission, as the baby will be advised two drugs for ARB prophylaxis. As both syrup, zirobudin and lopinavir/ritonavir are not available, baby can be advised pediatric FDC of Zedalan as per Weidman. And it has to be continued after 12 weeks and the mother opted for exclusive breastfeeding. In exceptional case scenarios and for high-risk infants born to HIV-2 positive mothers or for high-risk infants born to mothers who had received single dose of nevirapine during earlier pregnancy or delivery, opinion of success would be sought. So, any questions? Kiranji, please check
Thank you, sir, for this
the chat
wonderful
room.
session. Participants are requested to, if you have any question, please unmute their mic.
हेलो सर।
हेलो।
हाँ हाँ मैडम।
Please.
सर ये लास्ट जो आपने सिनेरियो बताया हाई रिस्क एंड HIV-2 पॉजिटिव, उसमें लोपिनाविर नहीं दे सकते बच्चों को?
ना वो नहीं है ना. This is not available. If you go through it, as both syrup, zirobudin and lopinavir/ritonavir are not available. In that case,
In that case.
if it is available, you will go for that. You will
हाँ.
go for zirobudin or lopinavir/ritonavir. But if it is not available, what to do? Then we go for Zedalan FDC. Okay.
No, but the scenario, the last scenario in which you said high risk because HIV-2 mother or baby delivered recently delivered unsuppressed. The last scenario, sir, the last line.
This one, no? This one, no?
The
Is
line.
it visible? 10 continued. Mrs. L delivered a baby by normal delivery with a weight of 3.2 kg and has opted for breastfeeding. What is
No,
the next step in the previous to that?
That the sasaprofil is required. That one. The
Yeah.
last.
It is in the guideline. It is in the guideline that exceptional scenarios for high-risk infants born to HIV-2 positive mother or for high-risk infants born to mothers who had received single-dose nevirapine during earlier pregnancy or delivery, opinion of SASEP should be sought. It was it is included in the guideline, recent guideline 2021. So we'll have to follow the guideline, no? I know you are capable of treating those patients at your ART center, but we also need to follow the guideline. So this is because of following the guideline, we should refer, no?
हेलो सर, गुड आफ्टरनून सर.
Sir, please tell.
काय विचारायचं ते? ANC चं जेव्हा व्हायरल लोड आपण करतो सर, मराठी चालते? जेव्हा
सर हिंदी में पूछ लीजिए.
हाँ, तो ANC का जो वायरल लोड करने का है वो 32.
Sorry, you can go for Hindi or English. I don't understand Marathi.
Okay.
हाँ, हिंदी में पूछ लीजिए ना, या फिर किरण जी you translate. Kiran ji, you can translate it for me also, no problem.
ANC का जो वायरल लोड करने का है वो 32 to 36 वीक में करने का है ना?
Yes,
दो बार करने का है या
एक बार ही करना है. So after 32 weeks, anytime you can do. It is best if we can do it within 32 to 36 weeks. Okay. But even if the patient comes later, say the patient has come just before maybe 7 days prior to pregnancy, and there is provision for viral load testing, then we should go for it. We should not restrict within 36 weeks. It should be after 32 weeks, preferably within 36 weeks. But if we fail to do it within 36 weeks, and if we can do it even after 36 weeks, we should go for viral load test. Okay.
Okay, sir. Thank you, sir.
Okay.
Any more question?
It's a very interesting subject. So many questions and gray areas are there. I was expecting more questions.
Sir, we can run a feedback poll. So quickly go through.
Please attempt all the questions.
Participants are requested to attempt that feedback poll. Thank you, sir. Can we conclude the session now?
If there is no question, let us know.
Okay, sir. Thank you.
Thank you all the participants.